Without further ado, I'm going to introduce our guest speaker today. The topic is telehealth, opportunities and obstacles. I'd like to welcome at this time Mark Swanson, the Vice President of Managed Services at Bright House Networks. He is responsible for the development of the telehealth initiatives. He will discuss the technical advancements and the new legislation that will bring his next big advancement of medicine to fruition. Not surprising that there's more legislation as it relates to communications in the medical field, right? Telehealth or telemedicine is the use of medical information exchange from one site to another via electronic communications, improving patients' clinical health status. Telemedicine includes a growing variety of applications and services using two-way video, email, smartphones, wireless tools, and other forms of telecommunications technology. Starting out over 40 years ago with demonstrations of hospitals extending care to patients in remote areas, the use of telemedicine has spread rapidly and is now becoming integrated into the ongoing operations of hospitals, specialty departments, home health agencies, private physician offices, as well as consumers, homes, and workplaces. I'd like you at this particular time to give a nice warm welcome to Vice President at Bright House Networks, Mark Swanson.
All right, well, it's great to be here. I'm glad everyone's awake. Everyone seems lively. I think Hank does that to all of us, so that's a great thing. I'll just do a little personal background, kind of tell you how I ended up getting to be looking into telehealth. And while I'm not an expert, I've been spending pretty much the last year focused on that. I am a serial entrepreneur, and that doesn't mean Kellogg's Frosted Flakes and stuff like that, but I've started in 6 companies, 6 multi-million-dollar companies, and sold 4 of them. And the last one I sold to Bright House Networks, and it's the business phone offering that Bright House provides today. And I think that's very relevant because the business model that we created in a cloud-based telecommunications model for voice is almost the same business model that I think works very well for telehealth. And I'm going to talk a little bit about that today and how we're going to do that. After selling the company, we closed the deal on December 31st, 2012. I spent about 4 or 5 months integrating the company, and I got into the very enviable position of having the smallest organization chart within Bright House. I had 0 direct reports. Now that suited me perfectly because I was thinking about my next venture, but unfortunately my boss said, hey, we're not going to have you out there just wandering around aimlessly, and we'd like you to, take a look at opportunities within Bright House Networks whereby we may be able to leverage the infrastructure and create new lines of business. So that's been my experience, and in fact, Bright House is my very first job working for somebody. So I left the military 22 years ago, started a company as I was getting out, and actually never ended up being employed by somebody. So to start my endeavor, I figured I'd start with the Affordable Care Act, because unlike Congress, I had to read it to know what's in it. And after about 6 or 8 months of reading that, I still didn't understand it. I said, I really need to put this down and come to another conclusion or look at another source. So what I did is I actually went out and I've interviewed probably 30 to 40 healthcare professionals and talked to them within clinical settings, mostly in the cardiovascular area. So I've been to 3 telemedicine and telehealth trade shows and spent I've read several books on it over the time, and then I've spent the last or the beginning part of this year putting together about a 60-page business plan, and I've read probably 150 scholarly research articles. So I've had the advantage that most people don't. This is what I probably is very exciting to me because I like to do this type of research and learn new things. But it's been very helpful because I've gotten up to speed on this, and so what I'm going to do is share this because most people don't have that type of advantage to take a step back and look at it. And I've been in telecommunications now for 22 years, and I think there's some very exciting opportunities bringing telecommunications to the healthcare industry and make some really big improvements. Does anybody know who this picture is right here? Who is that? Nope, it's not Clara Barton. It is. It's Florence Nightingale. So Florence Nightingale lived in the mid-1800s, or 1800s, the 19th century. She was a daughter of a member of the House of Lords. In fact, her grandfather was the head of the House of Lords, whatever they Speaker of the House. I don't know, is that what they call it there? I think yeah, Lord of the House. And her father was actually a very wealthy entrepreneur. He was a wine importer. And back then, you know, society was stratified into two classes. And generally, the military conscripts all came from the common class. But Florence was very dedicated to nursing and really had a passion for that, and was deployed to the Crimean War. Now, there was an interesting technological development that happened just prior to the Crimean War that really affected the outcome of that war as well as the outcome of healthcare. Can anybody tell me what that development is? Yes. It was the telegraph. So the telegraph was invented in the 1840s, and the Crimean War, where the British were sent to the Crimean Peninsula, and we're still messing around with that now. Now people know where it is. I've told this story a year ago, and everybody had no idea where it was, but most people do. So the ability to go into the Crimean War and have daily reports of what was coming back was very different than you ever expect in warfare, because the news used to travel back, and from Crimea it would take a month or two. So the British royalty never really knew what was going on. Well, because of these telegraphs, you know, when one of the lieutenants or officers that came from the royalty family or from the upper class families would get wounded, they would send telegraph messages back and say your son got shot in the hand, or, you know, shot in the foot. And then people would say, oh, great. And there was actually relief on the mothers of those sons because they said, hey, they're off the front lines. And then 2 or 3 days later, they would get a telegraph and said, you're sorry, your son has passed away. And this happened over and over again. And it created great consternation amongst the members of the House of Lords. And so who was down there but Florence Nightingale? And she came back and prepared a testimony in front of the House of Lords based on what she had learned and about the abhorrent conditions that the the hospitals were in there. And it was really bad. I mean, they used saws. There was no germs. You know, people were left to die. And in fact, you had a better chance of surviving being on the front lines of the battle than going in for nicking your finger back in the hospital. So it was a disease-ridden thing. And I think it was, if you were admitted to the hospital, 49% of those people died. So it was really bad. And this was the catalyst for statistics. And then some of you in the medical field have seen those charts that Florence Nightingale has drawn, and really created an entire understanding of the effect of cleanliness and how we take care for people. So that's really where telecommunications industry started, with a relationship with the healthcare industry. And I think we have a great deal we can do in the future. Now, before I really get started on the talk here, I would like to define telehealth, because it's a broader category than telemedicine. Telemedicine has really been around for 40 years, like Hank said, but it was really involved with taking our existing healthcare system and extending it to rural areas. People that couldn't reasonably drive to the caretaker facility, the hospital or the clinic or wherever. But today we're actually looking at extending this as a method of business wherever you're at, because telemedicine can be used even if you are, or telehealth technologies can be used even if you are in the hospital or next door to the hospital. And it's really involves three things. It's preventative, meaning we see a lot of things that are related to telehealth with fitness today. And how many people have like a Fitbit or one of those things on? Anybody wear those? So I'm wearing one right now. And that information is designed for personal use, but it's really probably changing a lot of people's behavior, and it's starting to revolutionize the edge of medicine, because now we understand what our bodies are telling us a lot better. It can be also promotive, like videos, educational type stuff, pushing and get people to learn about that, as well as curative. There's now devices out there that can take full EKGs at home. There's a device now, I was getting briefed on it a couple days ago, that you can put a drop of blood in it, and it will electronically transmit the data that will tell you whether you're actually having a heart attack or not. So think of the revolutionary type of thing that is, where you go into the hospital now and you're automatically admitted to the ER, and I don't know how many false admittances there are to the ER for heart conditions, but they always err on the side of safety. But that's changing, because the ACA is basically saying, hey, those rates are too high. You got to not admit people for that. So that's what telehealth is. And it's really a new business model. We have a business model today in healthcare that's break fix. Doctors, hospitals, everybody makes money when people are sick. And I think the technology exists out there, and what it lacks is the business model. But that technology exists out there to really create a wholesale different approach to healthcare, which is keep people out of the system altogether, keep them well, keep them healthy, and get early indications that let people know that their health is trending in the wrong direction. And that early intervention, whether it be from a simple phone call, it might be a nurse visit that comes by, or talking to your doctor on your cell phone, that's what's going to change healthcare. So if you think of healthcare, the industry itself, it has really remained unchanged since before I was born. The hospital system today is essentially the same as the hospital system of 1953, except it's a little more crowded. So, over 60 years, all we've really changed is the equipment. And I've been involved in the internet. I got involved in the internet in 1993, and that's been pretty much my career. If you look at the industries that the internet technologies have completely disrupted, I mean, it's a long line. Think of the travel agency. I was involved in the project that built the very first reservation system on the internet. That was with Holiday Inn. It was 1994. And I remember the CEO of Holiday Inn, we launched it, and that first day we had, guess how many reservations we had on travel? What? 2. And the CEO declared it a failure. And people wouldn't do this. I remember giving him a briefing, and we were showing him the website. Now, he had never seen a website. And in his next action told me really how far behind it was. And so we handed him the mouse, and we told him to click on something, and he picked it up and went like this. But the travel, and I mean, we couldn't imagine not going online today to do our travel industry. I mean, it's research, and some companies got it. We built a website for Mountain Travel SoBack. It was the first travel agency actually on the internet, and it's still thriving today. I'd say 90% of the travel agencies that exist back then are gone. Kind of the next industry we disintermediated was the retail industry. I mean, a bookseller now is the dominant retail company in the world. Yet, other companies, Sears, why didn't they think, have some foresight and say, hey, let's just change our business model. We're falling behind right now. They could have been Amazon.com and been the massive retailer. The next industry is the financial services industry. I remember bankers. I built SunTrust.com and Chase.com in my company, and the bankers said people will never use this. They will not trust the internet to do their banking, and they were so certain of that. And yet now we've got online brokers like E-Trade that dominate the industry. Charles Schwab got it. They got it early, and they made the transition, but many companies are gone. Then you look at the media industry. Here's a question I have for you. Why isn't Blockbuster Netflix? They had all the movies, I mean, all they had to do was hire like 50 developers and build a site to get people to stream them. I mean, they completely missed the boat. But now we come to the healthcare industry. Why do I have to go into the doctor's office who gives me a 9 o'clock appointment and it's never on time? I sit there, it's 9:45 before I go into one waiting room to the other waiting room, and then he comes in there and he spends 10, 15 minutes reading my charts and checking me off. And this is after I spent 15, 20 minutes filling out the same form I did the last time I saw him. And then he says, everything going good? Your vitals look good? Hey, you're doing great, thanks. And then he leaves. I literally, the last time I went to the doctor, I had a 30-second encounter with my doctor. Yet I paid, several $100s for that. That is an industry waiting to be disrupted. And the problem we have right now is it's completely screwed up. And I think that the best thing about Obamacare, after reading all those 2,256 pages, is that it stuck a pot in the healthcare system, and now everybody in the healthcare industry is running around with their hair on fire. So I think that's a great entrepreneurial environment, and I'm excited to be in it. So there's three macro trends that I think the healthcare industry we can really leverage. And number one is there's an urgent demand for cost reduction. And we're going to talk a little bit about that. There's a ton of new technologies out there that are coming out, and there's some big changes in the regulatory environment. So let's talk about the cost epidemic. These are numbers that probably some of you have seen. It is outrageous how much we spend on healthcare. My daughter had 2 open heart surgeries. I spent $500,000. I personally was out over $100,000 on that. And while she saved my life and I had great doctors and I'm very grateful for them, it was a very expensive endeavor. Now the thing that really caught my eye off this slide here is how much we spend on chronic conditions. And you've heard these statistics before. Half our healthcare costs in our entire life are in our last 6 months of our life. And we are prolonging people, and in chronic conditions, the big thing that everybody's got their hair on fire in the healthcare industry is this readmission rate. Everybody knows about the 30-day readmission rate, and that's probably one of the biggest things in the Obamacare is that 30-day thing, because everybody's like, how do we stop the 30 days? And in chronic conditions, it's really out of control. Congestive heart failure, for example, over 25% of patients that come into the hospital for CHF are readmitted within 30 days. And the worst 25% of those CHF patients go to the hospital through the emergency room normally, an average of 2.5 times a year at an average cost of over $25,000. And Obamacare was supposed to make that cheaper, right? So I just got the statistics from Florida Blue. And that $25,000 number, theirs was a little higher. It was about $28,000. That number's jumped up to $39,000. So we're going the opposite direction on average readmission rates. So something's wrong with the system on the cost. And we spend way more than anybody else per capita. The other developed countries are half or under. And if you take an average of the 20 countries, top economically developed countries behind us, we spend 2.5 times more. Yet we all know that our outcomes are worse. We have higher mortality rates, our lifespan's less, our childbirth rate averages between 20 and 30 in the ranks on this country. So we're not doing a good job, even though we're spending so much money. But I think mobile digital can really impact that. How many people have heard of the Internet of Things? All right, so I would write that down and I'd Google it, because this is the next big thing in the Internet. And we've had 3 waves of the Internet that I've participated in. The first wave was kind of that one-way communication. It was all about websites. Remember when everybody was talking about their homepage? You say, hey, what's your homepage? I got a homepage. You got a homepage already? Really? Yeah, I got an email address with my own domain. How did you get that? That's what it was like, 15 years ago. It was like, everybody back then had, at AOL.com or at MSN.com. But when I had at Swan.com, I thought that was so cool. And I figured out how to do that. But the Internet of Things is that wave that comes after the second wave, which is really the social wave where everybody's talking to each other. And now it's the third wave where not only are people talking to each other, but devices are talking to each other. And they can tell us some very interesting things. And these are some devices on here in the healthcare industry, things like weight, blood pressure, blood sugar levels. The second trend is this thing called the quantified self, and you're a part of that. If you're wearing a Fitbit or a body media thing right now, then you are a part of the quantified self. And that's a movement, and it's really popular amongst young people, whereby they like to measure their fitness. How far did I run? How long did it take? How many calories did I burn? You know, take a picture of everything I eat. How many calories did I eat? This is my weight. I mean, there's people that are so into this, right? You probably know who they are. And the third thing is this big data. I mean, big data today is revolutionizing healthcare, and it is doing things and finding out patterns and recognitions that are really impossible to find out through things like genomics, and then bringing that data right to the bedside through tablets and technology, so that doctor can actually query the data that they're collected from the hospital bed, send it back, and within 2 or 3 seconds, come back with a good diagnosis. And you probably heard about Watson. Does anybody know who Watson is? Watson is IBM. That's the big computer that won on Jeopardy against, now they've got Watson plugged into the hospitals, and Watson does by order of magnitude a better diagnosis than any doctor out there. It can come up and say, here's the probability of the conditions that you have based on the data that you have. And even rare, so when there's a condition they're struggling with, they give it to Watson, and 9 times out of 10, Watson is dead on. So that's, that's just the edge of what we see. The first two technologies, notice where they're at. They're at the edge of the healthcare industry. The last is in big data, even though it's in the back. But think about this. In the last 10 years, where have all our healthcare dollars gone? Does anybody know? It's gone to healthcare.gov website. No, it's gone in the back end. It's gone to our EMR vendors, and think how much money we've spent on trying to integrate all this data out there. And here's another question I have for you. I literally have no idea why this is true. Why is Epic the leading EMR system? It is the worst. That's every doctor says, oh, I hate Epic. I have not talked to one healthcare professional that likes Epic, yet you look at the market share that they have, it's great. So, it's like Microsoft. Maybe they had Bill Gates advising them. The last thing is changing healthcare laws. I've talked a little bit about the Affordable Care Act, and this is a very laudatory goal, to move the system from fee-for-service to fee-for-outcome, because we are not being measured today by outcomes, and I think that's where the goal is. I think we're going about it in the wrong approach, but therein lies the opportunity for healthcare. We also have Medicare and Medicaid. Right now, Medicaid administered by states, they're all over the board on whether they accept payments or not, or they'll pay for things. A couple key dynamics on Medicare. Number one is most states won't allow you to cross state lines, even with telehealth. And most states, in order to get reimbursement, you have to today in Florida, you have to be 50 miles away. So if you live 9 miles away from a clinic, you cannot use telehealth and get reimbursed for it. Now that just doesn't make sense to me. And then state laws. Now we did come very, very close this year on our state laws passing a telehealth law, and literally at the 11th hour, HB 7113, that was the House bill. The Senate bill was 1646, and there was other bills that got morphed into that. But we passed every committee in the House. We passed the full House vote. It was kicked up to the Senate and went through all the committees in the Senate. And then at the 11th hour, Thursday night, less than 12 hours before session was supposed to end, a amendment by somebody that probably knew some doctor was put in and said, hey, I do not agree that doctors outside the state should be allowed to practice within our state without a state license. So that bill today was, I think that could have been easily rectified and just said, look, let's just get started. Let's go ahead and allow, make you have a Florida state license. So if you're licensed to practice in Florida, you can be in Georgia, for example, and practice in Florida. But I think, and I'm not going to read this to you. This is in your handouts there on your table. But this is a summary of each one of those bills. I believe it's a top priority. I have consulted on this. I've been up in, now we have to speak through lobbyists in the cable industry. We can't directly attribute our comments to the specific company, but I briefed the lobbyists who got up and then in front of the Senate and briefed them on what we think the bill should should obtain. But with the exception of safe harbor provision, I think this has got everything we need to do a really great business model in telehealth. So let's get a little more specific. What is, when we say telehealth, what are the top applications on it? Well, remote monitoring is number one. I mean, telephonic device, a lot of diagnostic technology is out there, and that's kind of where the focus is on telehealth. Now, when I'm talking about telehealth, a lot of these are mostly the applications of telehealth to getting healthcare from the hospital or from the clinic to the home. If you look at the market size here, it's projected to grow very rapidly. These are broken down by diseases, but the top chronic conditions, this is where kind of in the sweet spot of telehealth, are CHF, COPD, and diabetes. And then that's pretty intuitive. And things, if you look at things like CHF, really a daily weight reading would help identify patients that are early stage CHF more than anything. So most doctors will say, I want three things. In the study that we are working on with Baycare, we're measuring three things. We're doing weight, we're doing pulse oxidation, as well as validation. We're taking a little video when they take their pills. So medication obviously is very, in fact, medication compliance is like the worst. And 50% of people admit to lying to their doctor about their medications. The other 50% are lying about lying. So, and I know my parents, my dad, he's supposed to take his medication. And you ever go in your parents' closet or medicine closet? I mean, how does he take his medicine? Yeah, it is scary. And I know he doesn't take the medicine when he's supposed to. And my father's a diabetic, and we're always freaked out about, what's his sugar level? And we literally took his car keys away because of diabetic episodes. He crashed into a tree, not once, but twice. So he no longer drives, but and he doesn't do a particularly good job of taking his medication. So I think that's another area for telemonitoring, or where parents can be monitored by their kids. And there's been a lot of studies on this monitoring stuff, and I'm focusing on monitoring because I think that's where the biggest opportunity is. I mean, I've got about 30 studies here, but look at some of the results, and I'm focused now on this readmission rate because that's all the hospitals care about, because they don't get paid if somebody comes back within 30 days. And so it's interesting to me that every hospital system tracks their 30-day readmission rate. And then I ask them, what's your 6-month readmission rate? And they have no idea. So the best thing, that was another great thing to come out of the ACA, is the fact that it's got this attention on readmission. That's a good thing, but I also think we ought to track it at 6 months and a year. But every one of these studies, look at them, 44% reduction in readmission, 65% reduction in readmission. Go back to that figure I said it's costing you $25,000 per readmission. You cut that in half, times the number. In Florida alone, it's between a $2.5 and a $2.9 billion problem. In the United States, the readmissions are over $20 billion just for CHF, just for one condition. We're talking about a $2 trillion industry here, so the numbers are kind of boggling. If it works so well, though, why isn't everybody doing it? That's the question I had. Well, first of all, the financial factors, it's really hard to get paid right now, and you have to fight with Medicare, Medicaid, and it's somewhat ambiguous value. There's no incentives right now to incorporate telehealth into your business processes, and it has to be integral to your business processes if it's going to work. It can't be just a bolt-on. And there's not that real-time feedback, and it's a lot of times it's inaccessible. I mean, you're dealing with a population that's generally over 65. A third of them are probably, have some type of dementia. A third of them are, probably, have some type of other chronic disease, and then the other third of them are running around looking for mates. So you have a lot of distractions there on it. But I think the Affordable Care Act and new mobile technologies are changing a lot of these factors. So, and if you summarize the issues with remote monitoring, you really have 5 of them. It's sometimes the connections aren't very reliable. It's a business that's very difficult to scale because you don't have any concentration. You know, old people live all over the place. Now in the villages it would be a lot easier. But in this case, you know, if you look at Metro Atlanta or Metro Orlando or Metro Tampa, it's hard to be able to deliver services to that spread out of people. And the device is not working. A lot of times the battery lives are fairly short on the scale. For example, the scale is 2 to 3 months. And, you know, I know for my father, it's hard for him to figure out how to change the batteries. And I'm not being facetious when I say that. It's, you know, you have to get all that, and he would rather watch sports anyway. So, and I think at that, a lot of people are like that. Privacy and security is a big issue. We still have HIPAA laws we got to deal with. And then the biggest one, I think the one that is the hardest to solve is patient compliance. Just getting people to care and put your monitors on, go step on the scale, go take your pills. I mean, and it is, you know, when you have chronic conditions, especially multiple chronic conditions, I mean, it is a management process. And I think, you know, I've dealt with, my mother had, in fact, my mother passed away with CHF in the last 2 years of her life. I mean, it was an endeavor to get her to take care of herself. And, you know, there's some big motivational issues there. And that's one of the drivers that's costing so much here. So if you look at the telehealth model, this is what we're looking at doing. First, you know, instead of using outdated devices that are built by engineers or doctors, let's use some of these consumer level devices that are designed to be easy to use. And there's so many out there. I just went to the TeleHealth International Telehealth Association show. I was out in Baltimore. I literally went there. I was there this week. I mean, everybody's got a new monitoring device. It's exploding. So I think there's plenty to choose from. Second, you have to have some network redundancy. We have an advantage as a cable provider because we have wires into 2.5 million homes today in Central Florida. And so we can provide that wireline connection. And and probably you don't know this, but we actually have about 40,000 endpoints that we lease from Verizon, the little devices, and because we buy so many, that's our backup. And in fact, for our home security automation offering, it's completely backed up, wireline and wireless. And I think you need that for the healthcare industry too. We have the ability to secure the data at the point of collection, transmit that data secured all the way back to a federated database that's HL7 compliant, and put all that data in there, and then that database can then interface with the EMR systems like Epic. The other thing we got is we got all these trucks. We got 750 trucks driving around. You've probably seen them on the logo. They carry routers and phones and cable boxes right now, but there's no reason why they can't carry scales or blood pressure monitors. And then what we're working on building right now is that federated database that collects all this information on a real-time basis, has algorithms in there that will take a look at the data and say, whoa, this guy's gained 2.5 pounds over the last day. You know, he's a candidate for going into congestive heart failure. Oh, you know, wow, that sugar is 300. You know, that's really high. This person's doing a very poor job at managing their diabetes, and then we can take preventive action out of that. So anyways, that's, and then the patient would get a new treatment plan. You have everybody now has smartphones, or we have tablets in the house that can communicate and update that treatment plan, change the therapy, and then make the patient better. So, and do this way, way beyond what we're doing today early, and those, 1 degree course corrections early on make sure that you never get so far off course later. There's a ton of opportunities in this telehealth, especially in the remote monitor. I talked about all the different devices on there, and then things even like monitoring for pediatrics, remote baby monitors, pedometers, interactive messaging on the databases and stuff. You also look at the different business models over there. You got the healthcare provider. That's what we're all talking about today. But disease management from the pharmaceutical perspective, we could do clinical trials with healthcare providers and with diet or fitness, doing wellness programs within companies. I know just working with some of the insurance companies, they are willing to pay companies to have their employees enter a fitness program, especially the ones that have those diseases, and give them discounts on on their healthcare plans to help them better, and that's going to create a much better system overall. So I think we have a great opportunity to I don't know what everybody else does here, but I think over the next 10 years, we are going to see the healthcare industry change more than we have over the last 60 years. And if you look at the other industries out there as examples of things that are done completely different today, I believe that we are on the precipice of rapidly accelerating the change and moving it from something that is more fix you or curative today to something that is more preventative and focused on keeping you out of the system and keeping you well, which overall I think is a good thing. And it's very, I think for an entrepreneur, a guy like me, I think this is the biggest opportunity in my lifetime and yours. So I would encourage you to spend some time to look at this, and I'm going to stop now and see if anybody's got any questions.
You're going to take a seat there. Please remember to give me an opportunity to get to you so that we can get your question on the video as well. And I've got a question back here. So.
Yes.
You ready to field these, Mark?
All right.
It's actually not a question as much as an observation as a clinician in the field with the telehealth. There's a lot of things that just are not yet connected with telehealth, and that is that it really takes a tight teamwork between a home health company and a physician to really make it work. And what we found is that we keep identifying with the data that these people are in trouble, but then you've got to have the resources to send a nurse to respond to that, and you've got to have a doctor who's going to immediately respond to that as well. And there's a lot of lag there. So there may be a lot of savings to the hospitals in that readmission, but they need to reallocate some of that money towards the resources that have to respond to that. And that's where it's fallen apart. We see compliance issues with the patients, certainly, and also patients can't really handle the technology. So sometimes they actually need a professional with them to step on the scale, or they fall trying to get on and off, and they don't know how to put the blood pressure cuff on and that sort of thing. So you end up with those kind of issues, and it is a tremendous resource, and it's definitely going to get those kinks worked out over time. I see it definitely working. But right now, as one of those people that's trying to implement it, wow.
Yeah.
Thank you for sharing that. Mark, you must have some comments related to that.
Well, I haven't, I'm coming this from the outside in, so I've heard many people echo your comments, and that's what, I said, and that's probably one of the biggest problems is it can't be treated as a bolt-on. It has to be integrated with the overall healthcare environment, and I've had many people tell me that. I don't have any first-hand experience, but I'm really happy to hear you say that.
Right. We have a question over here.
Hi, my name is Tatiana Melnick. I'm an attorney, so I work on the back-end contract side. I'm curious what you're seeing on the integration front. So this is a great environment, so you're going to get a lot of information, but in order to share that information, you have to have those devices work together. And what I'm seeing is developers and companies don't want to share. I know the FTC has been a little bit more active on this front lately, but what are you seeing from the back end?
Well, you're absolutely right. Is the data is kind of viewed as the golden goose, so to speak, and so there's a lot of new entrants from a technology perspective that really are basing their business model on getting the data and then being able to massage it or just provide feeds back to other people because that's something that's perceived to have a high degree of value. My thought process on that is I think we've been like that. Many other industries were in a similar situation where they didn't want to share, and what ends up happening is you end up with standardization over time where data is shared. But what often happens is market leaders emerge over time, and then that becomes a standard. A good example is Microsoft Windows. It wasn't the best thing, but when it came out in the early 80s or I guess it was the early 80s, not Windows, but when Microsoft came out with their operating systems, I mean, there was I was around back then, and there was probably 20 different operating systems that were in contention, and they all whittled down. And once that became the de facto standard, then everybody kind of migrated to that. And I think, we've got some ways to go before we reach that, because we frankly have, now probably 100 different startups that all are pitching venture capitalists that are saying, data is how I'm going to make my business model. And unfortunately, 90% of those will either fail or 95% of those will fail or get gobbled up. So it's an evolving process that is natural in this environment. And what I hope doesn't happen is that the government tries to pick the winner. So I hope we are allowed, some market semblance of a market. But
Yeah. And Mark, quite frankly, we're still in an infancy growth stage. The thing is, though, that technology goes so quickly, we keep getting into these growth stages and trying to always catch up. Good deal. Louie, you had a question.
Yeah, really enjoyed this discussion today, Mark. As we make this paradigm shift between sick care and true healthcare system, are you able to see any regions in the country or any companies that are kind of showing the way of what it's going to look like? As you're well aware, Google Health backed out, Microsoft Vault, getting your personal health record online, something that people don't want to do for that patient engagement piece. Do you see any companies or anything that kind of maybe the way of the future?
Well, the interesting thing is the companies that are taking the lead are doing it in areas of the country where they have passed telehealth legislation, where Medicaid reimburses for remote procedures. Texas is a good example. They have a lot of telehealth studies came from Texas on here. Kansas has got a telehealth law. The difference between Kansas, New York, and Texas, though, is Texas didn't mandate didn't say what the fees should be. Kansas, on the other hand, actually said, if you're going to take your weight, we'll give you $12. Blood pressure costs, $9. And so they created a fee schedule, and everybody migrated to that fee. And in some cases, there's an interesting paradox in a technology industry where you have a set fee. What happens is everybody races to find the minimum acceptable effort to hit that fee. So and because there are government contract bids on it, you end up with the worst possible service. So whereas if you let the market forces and don't set the fees, you let the hospital companies, and the healthcare companies determine, hey, who's doing the best job for me, and it's a fee combined with value that ends up winning. And that's the approach I advocated for Florida. That's the approach that's in the proposed telehealth law. So I think the best possible result is to have open the kimono, so to speak, with that data, allow a lot of companies to provide, and then we'll determine who's doing the best job for the dollar, and that's what will be the marketplace to win. The question was there ever entertained a scenario where the fee goes to the patient? So, and we have some interesting ideas around that. I'm not going to discuss them right now, but it may not be dollar pays, but there's other ways to motivate patients to be able to do that.
Hello, I'm Jeff Holt with PNC Healthcare Business Banking. So, question. In Michigan, actually, Tatiana and I were part of a group on telemedicine and kind of promoting education on that. And I get it why Bright House would want to be part of something like this. And I know that we all know that eventually the laws will pass here and reimbursement will happen. But focusing more on the telemedicine side, where connectivity, direct connectivity is not feasible or is not there, is there anything that you're working on in that area regarding the consults from that aspect? Because I can see the other aspect is for you is once the law's passed and the consults can happen, then obviously that'll be a service that you'd be promoting through Bright House. But again, what about in the wireless form? Is there anything you're looking at just so that there's a solution there when there's a need, and that you can't say, sorry, we can't help you? Is there anything you're working on in that space?
Yeah, well, so I'll also kind of answer the question, the preface to the question, and there's a lot of development going on and making bandwidth higher. And as we know, a lot of these applications need bandwidth, and it's both wireline and wireless. Bright House has almost 30,000 wireless access points in our territory now. And if you're a Bright House customer, I would encourage you to do this because it's all free to you. In fact, in this building, if you pull up your cell phone, you'll see Bright House, and you also see cable Wi-Fi, which gives us access to over 300,000 Wi-Fi access points throughout the nation. So I've got I got 8 cell phone plans, and I've got them all pairing with the Bright House, and I only use 10 gigs with 4 kids on the plan. So it might, which is pretty impressive because I make them go to places that have Bright House but you can do the same thing. We also have partnerships with cellular carriers. So those areas that we can't match or get to cost effectively, we can do that. And we have, as I told you, we have a contract with them, and we've got 25,000 cellular devices, data devices that plug in and primarily serve as backup today. And I believe that backup is very important. And in fact, I think one of the issues, when I say backup, is if one or the other fails, but in many homes, and this is true in my home, I can go to a corner of the house, I don't have any cellular connectivity. And so it's difficult to penetrate through walls, and I think having that redundant connection is going to be very important. The video and encryption, once that video is encrypted, so the question was, what happens if on wireless it's unencrypted? The encryption is done at the endpoints. So we control the endpoints on there. The data is encrypted. If we have our equipment on either side, what goes in between is completely encrypted. So we solve that problem that way. And even though there may be like a healthcare system that has an outlying location, like in Sebring or something that you can't get to, we could put our equipment out there and do that wirelessly. And the other thing to note is that we're already seeing a lot of demand right now for video in hospital systems. As you know, the hospital systems have been consolidating. They're all over the place, and a lot of them own these clinics. They're moving down market. There's a lot of movement, and primary care physician concentrations need access to specialists, which may be in hospitals. So having that video equipment on net, it has nothing to do with the home, but we've got people that are asking to provide that type of video conferencing today to do that, and I'm working on an offering specifically on that, just from clinic to clinic or clinic to hospital.
Over here, Dan. Dan O'Connell, Book of That Doc. I'm not a clinician, thank God for those patients. Mm-hmm. And I don't know if they're relatable, but 2 of your displays struck me. And again, I don't know if they match, but on the sliding scale of the top 5 applications of telehealth, 18% is on specialist remote diagnostics. Primary is a little bit above that, but my question is, the other item was the 84% on chronic conditions. Are those in the specialty category, or is that something we should shift all the more into to monitor those patients that typically have chronic diseases?
Yeah. Well, keep in mind that data was sliced completely differently. So, but chronic condition care includes everything from, the medications, the number of consults that chronic patient has to go in, the number of ER visits, and all that stuff, versus the telehealth monitoring is based on what is going on today, and that data is probably 2 or 3 years old. So, but I think to your point though, absolutely, I think almost all the focus should go on chronic conditions because that's where all the money savings are. And I believe the best way, this is another paradox, the best way to improve healthcare is to not focus on improving healthcare, it's to reduce the cost. And we really need to have, and this is the big thing I think on the Bright House approach, and what the approach I'm trying to do is like, let's get in there and reduce the cost. And we're not clinicians. I don't know how to improve care. I don't know how to do anything, but I do know how to extend the healthcare system to keep people out of the system altogether by early indications. And that's going to reduce the cost. And I think if you look at every other industry that was disintermediated, going back to the beginning of my talk, it all came from the outside. Disruptive technology does not get adopted from the inside out. It comes from the outside in. So, you know, who knows? Bright House could be the biggest healthcare provider in Florida in 20 years, you know?
Good deal.
In fact,
Next
we could
question.
drop our cable.
Hi, I'm Rodney with D&G General Contracting, and one of the main concerns that I find from the consumer end is security of their information going out over the airways, going out wireless, going out all the different methods that we have. What protects if I'm wearing a monitor and I'm sharing all my medical information over the airwaves? What protects my information with all the compliance and everything that we have at the other end? What keeps my information from being snagged out of the airways and being shared somewhere else? Where's my security?
So that's a great question, and that's something that I've expended a few brain cells on. I think the only way to solve that is to encrypt at the point of origin. And that's the first connection is from the device, which is generally Bluetooth, to the first collection point, which is generally some type of computer or tablet technology. It could be the set-top box. You know, Bluetooth is not a very secure technology. I mean, so people can collect that individually. We're looking at using wireless within the house, 802.11 encrypted, so you can't intercept that technology. The scale we're using, it's a Withings scale that has both Bluetooth and wireless. But beyond that is probably the bigger thing. You know, getting a point of data that, you know, hey, your blood pressure was 120/80 at this point in time is not nearly as valuable as getting your entire health history. That needs to stay encrypted in the database. So the federated database that we're contemplating, every field is encrypted. So all, you know, the data that is stored in there by field. So it would have, you know, your social security number be encrypted. Any, you know, every blood pressure reading that you got on every day would all be in encrypted field, and you'd have to have a key to be able to unencrypt that. And so when we share that with another healthcare provider, we would pass them the key, and they would be able to de-encrypt it. And you know, I haven't thought this detailed in the business process, but you know, maybe we share a different key every day, and so that you know, that key would go away. And there's a lot of banking. In my experience in the banking industry, I think that has a lot of the precautions that you are concerned about already built into it, and I think we ought to use that as a model.
Patient satisfaction, both at the hospital level and in individual practice offices, is becoming more and more a determining factor on contractual relationships with physicians and allowing physicians to come into a hospital and their reimbursement. The areas that are currently using telehealth and the areas that you have the studies, are there any studies being done on how the telehealth affects the patient satisfaction with the physician who's rendering the services?
Yeah, there are a lot, actually. So you're familiar with the Hiddison star ratings and the yeah. So those types of ratings, it's been shown that, you know, keeping people out of the healthcare system altogether is actually one factor that improves the ratings. Not having to go in and not making those, if somebody doesn't have any experience at all they know is they're being monitored versus going in and being seen an hour and a half late and having a bad experience, that gives them the opportunity to complain. So when you survey those patients that haven't been into the system, which half the people that go into the system don't like it anyway, so those ratings are going to be driven down. Just keeping them out of the system actually improves them quite significantly. The other factor, and I just thought of it here, is I can't remember. There was one other thing I was going to say. See, I'm already getting old, but yeah, Marty, I'm going to follow my dad here. So, but yes, there's plenty of studies out there that show that that telehealth improves those star and HEDIS and all the ratings that you guys use.
Mark, let's talk about the bottom line. 80% of the costs in healthcare are still an employee cost, correct? It's the nurses, it's the admin, it's the doctors, it's everybody. Yeah. Telehealth is supposed to reduce those costs, and it has the most significance. So what functions are moving to either back office and are, just an example, the earlier areas where telehealth was used is in radiology. to look at those results from India or from another state, right? Are these laws preventing us from utilizing those types of services outside of the state to be able to do the reading radiology exams, mammograms, things along those lines? And what kind of effect does it have on that bottom line when they can use those services?
Well, things like radiology, I mean, there's laws that allow that today. So, even overseas, I'm not sure if Florida has that. You can send them overseas in Florida. Who knows that? Maybe not. But there's plenty of states that allow you to send things like radiology, mammograms to experts, pools of experts, and we, just it's intuitive that having concentrations of people that do a repetitive process can do it both better and more time efficiently, and which is why we're allowing doctors from India to read those, because there's a great cost savings. But the bigger cost savings is really driven by a change in the model. So today, elderly populations will go in to see their doctor many times a year, and whether they need it or not, and you're always playing catch up. The doctor would, spends his 30 seconds looking at your chart and basically reviewing your stuff, and then either saying, hey, everything's all right, or maybe we need to take a closer look here. What we're shifting to is a model of that you need it. Now, the car industry has shifted in many fleet management systems, for example. You don't change the oil unless the dirty oil indicator tells you that you need it. So they're saving billions of dollars in automobile and fleet management systems by only addressing those things that need it. And by monitoring people on a daily basis and keeping them out of the system altogether, they don't have to come in every month or every 2 months for a visit. They can come in when they need it. So not only are we offering keeping people out of the system, but we're only bringing them in when they need it, and we've got the context because we have a month or two, or in some cases years of history to look at trends to see how they got to that point. So that better information and the fact we're only seeing those people at the point of when they need the care, I think really drives the cost out of the system.
Great. And we're down to the end of our day, so we've got one last question. Bernadette, will you finish up for us?
I don't think that you would have this information right now on you, but I would appreciate it if you could post it on the website of MOROF after your video gets posted. But the question is this: utilizing providers from out of the country, how do the providers here get those providers credentialed to be in the billing system is my question. I don't know if you have that answer now, but if you can post something on where we could get that information, that would be helpful.
I don't know that answer off the top of my head. So.
Well,
but that's a good question.
Mark, we certainly appreciate your time and energy and information today. Please, let's give a warm thank you to Mark Swanson.